As cardiac surgeons, we've always been a little bit of the minority with ACure here, so it's nice to see more surgical data and presentations coming. I'm sure there's going to be more to come in the ensuing years for ACure. So I'll invite Hermann, who's been a long-time member of ACure here, to start us off.
Yeah, thanks very much. Hello, everybody. Jerry always puts the surgeons last because they try to speed up things at the end, and we can finish in time finally. Okay, so we were asked to show, present a few cases for surgical indications, and also maybe give a little hint for upcoming studies. So basically, there are different indications, as we heard already today, for the Impeller 5 or 5.5 use. Basically, now we want to talk about its use in cardiac surgery. And there obviously, the one thing we want to avoid in our patients is post-cardiotomy low cardiac output syndrome, because it is a very severe complication after cardiac surgery. It occurs in about 10 to 15% of all cardiac surgery with poor outcomes. This is, for example, STS database on patients with a reduced ejection fraction, and the mortality, as you can see here, ranges from about 5 to 7% if patients have a ejection fraction below 25% and develop post-cardiotomy syndrome. Now, obviously, we have different options how to use the impeller pump in these cases. We can actually prime them preoperatively with an axillary insertion a few days pre-op for optimization, so bridge to cardiac surgery candidacy. There's the intraoperative use, again, axillary graft and impeller placement pre-sternotomy, and there will be a trial, the IMPACT trial, which I will comment on a little bit later. And axillary graft and wire placement post-sternotomy but pre-coronary cardiopulmonary bypass. And of the third indication would be to treat post-cardiotomy failure, which in failure to wean from cardiopulmonary bypass, direct aortic or again axillary use. So I just want to present a few cases. This is a 63-year-old male patient, had a previous AVR about 10 years ago, deteriorated aortic valve prosthesis, ejection fraction 26%, and due to coronary anatomy was unusable for a valve-in-valve TAVR. So we did a redo AVR, inability to wean off cardiopulmonary bypass, so we did a Impeller 5.5 implantation. Patient was extubated after 4 hours, fully mobilized with the device on post-operative day 1, and the impeller was weaned and explanted under local anesthesia on post-operative day 8. Patient is doing well. Another case is what we would call protected OPCAP. It's a 74-year-old patient suffering from dyspnea, coronary angiogram, triple vessel disease, ejection fraction 22%, dilated left ventricular diameters, Swan-Ganz, deteriorated cardiac output, severe peripheral arteriovascular disease. So PCI was in the heart team not possible in this case. So we did, in this case, a protected off-pump coronary artery bypass with the use of Impeller 5.5 implantation during the procedure. And we've done 9 patients so far with this protected OPCAP strategy with the impeller insertion, and we received complete revascularization, and in-hospital survival was 100%. In this case, patients are mobilized after surgery immediately with still the pump inserted. Now, there are some planned trials in these cardiac surgical applications. There's the IMPACT US trial, which we've presented last year at our virtual ACure meeting. And as a basically spring-off, there is the IMPACT EU trial, which we're at the moment preparing in Europe. So it's use of the impeller devices in high-risk cardiac surgical procedure. There will also likely be a trial in using the impeller device for protected op-cap surgery called the PRIME trial, which is at preparation at the moment. But this is just basically a few discussions to stimulate our panel discussion. Thank you.
Thank you, Hermann. I think we'll just proceed with the next presentation, and then
we go to the discussion.
It's
fine.
Yeah, so I go on. Thank you for the opportunity to speak. I try to give some interesting aspects for the topic of impeller bridging to a durable VAD. We heard some aspects here, and I will focus on that. We know that outcomes, and here are data from the Intermax report, outcomes in cardiogenic shock, Intermax class 1 and 2, are inferior to those patients in stable conditions. And many centers use ECLS for stabilization of these cardiogenic shock patients. But, and we are talking here about the use of impeller in the role of improving patients to become an LVAD candidate. And for example, as a bridge to decision tool to make patients an LVAD candidate, and we published this a few years ago, and we optimize patients, and we don't implant these patients from ECLS, but improve these patients with an impeller 5.0 or 5.5 device, and then patients are in better condition or become LVAD candidates. So talking about a little bit more of the gold standard in many centers, and this is the, to date, as far as I know, largest multi-center retrospective study on LVAD recipients implanted from ECLS device from 11 European centers. There are more than 500 LVAD implants included here. And looking at the one-year survival, and I would draw your attention here, is around 50% in these patients. So we already have seen this figure over here, a very interesting manuscript which addresses many important aspects here of the interaction between left side and right side. And what is the problem? Why is it potentially beneficial to use an impeller 5.0, 5.5 device in contrast to ECLS bridging to durable VAD implantations? So in most centers, the ECLS is implanted in femoral vessels and patients cannot be mobilized. It's hard to evaluate the RV function on ECLS because the right side is unloaded and it's not representing the true function of the right side while on ECLS support. And the idea we have is that if we change patients from ECLS to impeller device, we have a true realistic idea on how the left side and how the whole hemodynamics are working. How is the right side working? Is it the providing enough cardiac output for the left side? And patients can be mobilized and really optimized. So we are ending up with a patient that is mobilized on a full flow device with axillary implantation. And the next step is only to implant the durable device. So, and we proved this concept with together with the Italian group in 9 patients. So it's just a feasibility study which we published a few years ago. Patients have been implanted with an ECLS. And many of these patients have been resuscitated, then were changed to impeller 5.0 at this time because 5.5 has not been available at this time, and then LVAD implantation in Intermax class 1 patients. So making long story short, we observed only, it's a small study, only 1 patient with RV failure, and there were no in-hospital death, and also the median survival was around 90% in these patients. And the same applied in the post-CE mark approval cohort in a multi-center retrospective fashion. And if you look more into detail into those patients that have been bridged to a durable VAD, we see the same 1-year survival or up to 1-year survival of around 90%. So we started the initiative because we thought how can we improve outcomes of patients with a short-term device bridge to a durable device. And we set up a retrospective study together with the Berlin group, and the goal was to collect the outcomes and adverse events after durable VAD implantation of patients that have been bridged by an axillary implanted LVAD. And we looked also for predictors of dismal outcome, especially also for right heart failure, while on successful impeller-only support. So I don't want to go too much into detail because the results are still preliminary, but we see here that 1/3 of patients have been resuscitated, and up to 40% had an ECLS before impeller implantation, or before impeller support. And here we see, again, preliminary results, not published yet. So we have 1 year survival in this multi-center study. More than 300 patients have been included from Europe. So survival more than 70% in this very sick patient cohort. And now I'm really looking forward to the panel discussion.
Thank you, Alex. So I want to start with you, Hermann, with regard to high-risk cardiac surgery. You know, we're seeing it's been hard to really, move this forward. We've been talking about it for years. Certainly, the technology has evolved and advanced and more surgeon-friendly. But we struggle with the fact that we face these high-risk cases. Our interventionalists are so good now with high-risk PCI that often these patients are being steered towards high-risk PCI, very nice outcomes, supported PCI, and we're stuck doing the surgical patients that are truly high risk with no alternatives. So what's the discussion that you're having with your cardiologists, and how do you make the decision about who's going to go towards a high-risk PCI versus the high-risk cardiac surgery?
Yeah, it's a very good point, Mark. I think we work very close in our heart centers. We founded that about 20 years ago. We sit together really every day at lunchtime and discuss all patients with triple vessel disease and main stem stenosis. And I must say, I'm sometimes my surgical colleagues say I'm too close to the cardiologist because I like to go to the cath lab myself and watch PCI in high-risk patients. And I think it definitely has its value. If we have a real high-risk patient and you can, with an acceptable result, you can do a PCI, I think those high-risk patients are probably better off with a PCI. But we are still left with, as you just mentioned, we are still left with a certain percentage. You cannot do a PCI, or patient has other factors, speaking diabetics or whatever, speaking for high-risk CABG. So we must have an alternative. And as you mentioned, those are really high-risk patients. And therefore, I think we need to have a strategy. And I think in the old days, just to do it, see what happens, and if it doesn't go well, maybe put an intra-aortic balloon pump in, and a patient doesn't do well, that's not an alternative. So that's why I think it's an excellent idea to have this impact trial that we say, okay, we have a high-risk patient group. It's clearly defined, and then we put prophylactically in impeller device and compare them with standard. Finally compare them with the standard care. It's a pilot trial primarily to really see whether the impeller pump will make a difference in these patients.
I suspect it will, and we've been talking about this for a long time, so I look forward to the data on that. But the one question then is, do you think how do you determine whether you're going to put it in up front, or you put it in intraoperatively, or it's the patient that you maybe try to wean once and then put it in?
I think what we learned from the intra-aortic balloon pump, I'm sure you would agree, although it's hardly used anymore, but what we learned, that it only worked if you prophylactically used it. If you sort of run behind and put it in too late, it didn't work. And maybe it was brought into miscredit for that. So what we've learned, I think, from that is, if we do it, we should really use it prophylactically. Now, prophylactically can be in two ways. Can be put in primarily already yeah, or if you try to come off bypass once and then while you are on bypass, you put it in. Those are the two alternatives. But to put it in at a later stage, I don't think that makes sense.
Yeah, I think you're absolutely right there. I think then the outcomes are already almost predetermined. I think with the impact trial, the other important things that we're going to see, the survival is one thing, but also looking at incidents of acute kidney injury and ventilator times and ICU stay times are all, in my mind, going to be positively impacted.
If I can ask you a question, what's your opinion on using Impella in off-pump coronary artery surgery?
Yeah, I was thinking about, why don't you just clamp those patients and do a traditional, coronary bypass operation as opposed to doing an Impella-supported case. But certainly, as we all know, there's a lot of value to not clamping, not having a bypass run, not having the kind of global ischemic time. And what we found initially with off-pump surgery was, manipulating the LV really impaired the RV. Yeah. And in these Impella-supported OpCab patients, the LV is decompressed. You don't compromise the RV as much when you're moving the heart around. And so I think there's a lot of credibility to it. I'll be interested to see the data on it as well. And I guess ultimately you could still, go on pump if you had to acutely, and then just come right off on the Impella device as well, which without clamping the patient. What's your experience with this, Alex?
In terms of around the cardiac surgery procedure, yeah, I think Hermann is right, and we know that from LVAD implantations, those patients who go on the ICU and decompensate at the later stage, they have the worst outcomes. So we should go up front and try to prevent post-cardiotomy failure. I think this is the crucial part. And if we use the Impella device intraoperatively, we stabilize the patient intraoperatively, but also in these crucial, let's say, 48 hours after surgery, we improve end organ function, especially kidney function, and we stabilize this patient, extubate this patient, mobilize this patient ambulatory on ward, as we have seen it, and then we can electively and step by step wean the device and make it a safe procedure for these patients.
So for you guys, direct aortic insertion in these patients, axillary insertion, what do you think the pros and cons are? And there's still a lot of surgeons that are uncomfortable with axillary cut downs, and it complicates the procedure a little bit. You need fluoro theoretically, or it adds a little more time versus you have the sternum open, putting the Impella in directly.
I mean, removal is of course the point, and the good thing about the axillary is you can do it on ICU. You don't have to move the patient to the OR. You can remove it. That's a big advantage of axillary. And we just had a case last week where the right side wasn't possible because it's severe atherosclerotic disease for some reason. So we put it in on the left side. So there's also an option to put it on the left side. So aortic would be our last choice.
I think there's some alternatives for when you do direct, for bringing the cannula or the graft out, such that you don't have to do a reduced sternotomy to explant. But it is nice to have both the options. With regard to the LVAD or pre-LVAD implantation, what do what's your gut feeling, and what's the mechanism there? Is it just getting them out of being decompensated? Is it, what else is at play there that's optimizing and changing these outcomes, which are really, remarkable?
Yeah, I think there are many aspects. One is patients receive the Impella device as a bridge decision tool at first, so they are becoming LVAD candidates. They have some kind of contraindications when they receive the Impella device, contraindications for durable VAD. And we have the Impella 5.5 device, which allows which gives us time to evaluate this patient, improve overall condition of this patient. And in the perfect setting, the patient is walking around on the ICU, and the only step that is missing, and we can all at all points evaluate left heart function and look for recovery of the heart. And if this is not, and we don't see, let's say, enough recovery of the left side, and we don't feel it's safe to explant the device, the only missing step is to implant the durable device. But end organ function is improved, the fluid status is improved, so we bring this patient out of this acute phase of cardiogenic shock and control infection, which comes often in these patients. And so the last step, and it's only a left-sided failure in a perfect setting.
I think, LVAD therapy, unfortunately, not among the cardiologists which are here, because they're heart failure cardiologists, but among general cardiologists, it's always considered as this, okay, it's a surgical procedure, has a mortality of about 50%. Why? Because we made the mistake and put them into the wrong patients. Because we want to help the patients, so put an LVAD in, Intermex 1, Intermex 2, and half of the patient make it, half of the patient don't. And I think in order to make it more acceptable as a treatment, which I think it can be, as the Momentum trial shows, that results can be excellent in the selective patient population after LVAD, we have to improve our patients before we put the LVAD in. Same actually what we need to do with our transplant patients. The times where we transplant patients out of ECMO are completely over because the results were not very good. And same we have to do here. We have to stabilize our patients before we put an LVAD in. And I think, in my eyes, the Impella 5 or 5.5 is a perfect device to bridge the patients, win time, let them recover, they can walk around, they can be mobilized, and then when they're in a good position, in a good acceptable condition, then they will have a good result after LVAD.
Before we open it up for any questions, what's your technique for explant of the Impella when you go to do the LVAD or heart transplant? Because we had some discussion about axillary artery issues and longer-term implants, yeah, and the risk of stroke and axillary artery injury. Are you of the school that pulls the Impella out through the apex as opposed to out through the axillary artery? What's your technique?
So we changed it a little bit. So at first we went through the axillary artery back then. Now we're going through the apex, we closing by manipulation of the carotides in order to maybe prevent a stroke. And after we change it from axillary explantation to apical explantation, we haven't seen any stroke complications. And fortunately, stroke complications are rare, but still, every stroke is tremendous for the patient and for the treating team. So that's why we changed it.
No, I agree. I think that's what are your comments? But I think that's a useful kind of change in technique for when you have that opportunity, yeah, to be able to pull it out from the apex.
Because we all have that experience, the bad experience, that if you just pull it out, that you can have a stroke. Yeah.
We have time for a question. Any questions or comments from the office?
What about
audience?
Bart's experience? Yeah. I would be interested in Bart's experience with removing, because we talked about it on the door before about it.
Yeah, I just do what you guys are doing. So normally I take them out from the axillary side, but if they've been a longer time, I follow the apical side, cut the Impella and take it out from apically. But actually I had a question towards you also on the subject of the last discussion. So it's great what you've done with the bridging to LVAD. I mean, you improve the patients, you get rid of right heart failure or the risk of right heart failure. The LVAD implantation is a lot less risky. But if you think now that we're going to have the BTR device and a longer time period, how much time are you going to leave before you make the decision for the LVAD implant? Because today, I suppose, that you didn't think about unless there was recovery immediately, but then when the patient is fine, you simply go forward for the LVAD implant. So how do you plan to do this? How long are you going to wait?
I think it depends on the patient and the treatment strategy. Are we having a bridge or transplant patient? Do we expect any kind of recovery? Is it a ischemic patient with no option of transplant? I think all these aspects need to be considered here, and there's no one-size-fits-all reply to your question here, unfortunately.
And the one sad thing, Bart, is until we have data with the BTR device, America has already done multi-center trials with the device, because at the moment it takes a long time to get certification for a new product, unfortunately.
Alex, Hermann, thank you very much.